May I request the House to please give a round of applause for the chairpersons.
Well, good morning, everyone, and I'm really delighted to have this joint session. We started with USI-NAUS session last year, and it was extremely successful. Everybody liked the idea, not only from the NAUS Association, but also from the USI Association. And I had overwhelming feedback from all our delegates and all our members of USI that this session not only should be continued, but we should give more time to them. And therefore, last year we had given 1 hour session for this. This year we have given 2 hours. And I'm sure in the years to come, this will strengthen our relation between USI and NAUS. So I'm extremely delighted to have this session. I welcome our special guest from Nepal and NAUS, and we all know them very well now. And I'm happy to start this session. I invite our first speaker, Dr. Uttam Mete, to speak on small renal masses. So Dr. Uttam Mete. Sorry, Uttam Sharma. Sorry, Uttam Sharma. Please come.
Good morning. Thank you very much for inviting us to this podium. We are very much delighted. Long live the friendship between USI and the NAUS, the joint sessions, and long live the friendship between our urological societies. So I'm going to talk on the small renal mass, which are less than 4 centimeters in size, comprises T1A or B. 85% of the patients with RCC that present asymptomatically, and the incidence is going on for the detection as well as in the renal surgeries. So the majority of the tumor size are less than 4 centimeters, having metastatic value of almost 2%. So the different studies in the different patients, the follow-up over the 35 months has shown the linear growth rate and volume growth rate higher with the metastatic of almost 2%. And as the size grows on and the size of the percentage of the metastasis goes on. So the majority are renal cell carcinoma, and majority are the benign and indolent, but 20% potentially aggressive RCC. The different management strategies are there for surgical excision, thermal ablation, and active surveillance. So the treatment trends in small kidney cancers are majority is going towards the partial nephrectomy. And there are some challenges in dealing with this one. The tumor biology is heterogenic and up to 2% risk of metastasis, and there is low accuracy in predicting the tumor aggressiveness despite having different clinical and radiological modalities. So there is called the treatment disconnect phenomena as well. So men and women survival, 5 years relative survival has not changed over the years. And the other slide shows that overall mortality rate and cancer-specific mortality has not much changed. So early treatment is not effective in changing the mortality. So increase in true occurrence of disease without change in the tumor aggressivity has not changed. So whether we are doing over-treatment or under-treatment, so that is the question. So what about the renal mass biopsy? 80% of are diagnostic. Tumor seedlings are there, not much, very less. With 93% has coincides with the final histopathological reports. With high-grade specimen also had the low-grade component, and even the multiple cause it goes accuracy beyond 93%. So there are indications for renal mass biopsy in active surveillance and ablative therapy. Other classical indications are there. So there should not be done renal mass biopsy in younger healthy patients who are unwilling to accept the uncertainty associated with renal mass biopsy. Older, frail patient who will be managed conservatively independent of the biopsy results. So there are different renal mass biopsy directions. Genetic molecular signature are coming up. Optical coherence tomography, Raman spectroscopy are coming up. They are the futures to detect the aggressiveness of the renal tumors. So there are some key points in surgical excisions. The partial nephrectomy is much preferred because radical nephrectomy as such will give us the overtreatment of 20%. Partial nephrectomy is strongly preferred in those patients who has got potentially important preservation of the renal functions like pre-existing CKD, abnormal contralateral kidney or multifocal or familial RCC. So what is our experience in our country? In my institute, 38 patients over the period of 5 years, mean age having 56 plus minus 16 years, has been operated in the size of 3.6 plus minus 1.7 centimeter, ranging 1 to 6.8 centimeter size tumors. The location-wise, upper and lower were the majorities, and the incidental and the pain symptoms were the main presenting symptoms, followed by the others. And as everybody knows about it, that the CT IBO is done in each and every cases of these conditions. So mean ischemic time was 16.9 plus minus 1.7 minutes, and hospital stay was 5 to 14 days, and there was no blood transfusions, and they had 3 complications with the pilocutaneous fistula were managed by putting the disease stent, and there was surgical site infections was conservatively managed. So the histopathologically, majority were clear cell RCC, and other 8 were benign conditions. So there was a stage in T1A and T1B. So there were no renal impairment, no recurrence. So what is the benefit of doing partial over the radical nephrectomy is it reduces the severe in CKD in 61%, reduction in cancer-specific mortality, and reduces the overall mortality, and local recurrence is not much, that is 1 to 2%. Despite having hemorrhage, urine leak, re-intervention was higher than the radical nephrectomy. So nephrometry for anatomical complexity was prescribed. So it is good for planning and counseling of patients. Reliable comparison of morbidity rates correlates with ischemic time, complication, and pathology. There are different nephrometry scores. There are while comparing the different one, renal scores correlates based with MIC, margin ischemia, and complications. Yeah. So there are different partial nephrectomy techniques, warm versus cold. Cold ischemia, benefit of keeping warm ischemic time less than 25 minutes is good, but once it goes beyond that, there is chances of losing the renal parenchymal tissues also. Cold ischemia safely facilitated longer duration of ischemia. Perfuse versus clamping. Off clamp is also comparable, equivalent to oncological outcomes, and different clamping techniques are there, RT only, RT venous, and super selective also. So traditionally 1 centimeter margin was advocated, but even less than 1 millimeter margin is safe. Negative margin is the priority, but it depends upon the surgeon's situation, clinical situations, tumor characteristic, growth patterns, and etc. So we can see up to 8% positive surgical margins, but there is no much difference between positive and negative surgical margin over the period of 5 years survivals, recurrence-free survivals. So to increase risk of tumor recurrence as found in Foreman grade 3 to 4, but not in the low grade. So we can see low risk, negative margin has got recurrence-free survival higher than the high risk positive margin. So what to do with the positive surgical margins? With close surveillance with a combination of imaging and laboratory evaluation should be done. If available, local resection at the site of previous tumor excisions has to be done either, or we can do ablative modalities or completion of partial radical nephrectomy, or we can put those patients who has got a low risk lesions or asymptomatic patient for the active surveillance. So in frozen section can be done. So it influences the intraoperative management more than 50%. It reduces the positive margins up to 8.5%. And there are a lot of different ablative therapies also. I'm not going in detail about all these things. So IUA 2017 has given some guidelines. Clinical T1A renal masses less than 3 centimeter size has to be approached. Percutaneous technique prefer over a surgical approach whenever feasible. Counseling regarding an increased likelihood of tumor persistent local recurrence should be performed prior to the ablation. Renal mass biopsy has to be done. So for the active surveillance for SRM, well marginated homogeneous renal lesions in the elderly or poor surgical risk, risks of completing non-cancer causes of death and intervention outweigh the risks of RCC progression. Active surveillance with potential for delayed interventions, like patient willing to accept the associated oncological risk. So active surveillance not advisable in potentially aggressive RCC except in patient with limited life expectancy, younger patient, otherwise healthy patients. So we have to follow active, in active surveillance by CT, MRI, and annual chest X-ray, CT chest has to be done. If biopsy malignant, then we have to go for the regular treatment protocol. So small renal mass in hereditary syndrome.
Can you come to conclusion?
Yeah, I'm coming. Yeah, BHL, HPRC and BSD less than 6 centimeters has to be done active surveillance, enucleation more than 3 centimeters, and RPLND has to be done in those cases, so MRI for follow-up in those cases. So this is the take-home message for the partial nephrectomy, young, healthy patients, active surveillance and ablations for elderly or poor surgical risk, ablation, enucleation for solitary kidney, renal insufficiency, hereditary renal carcinoma with multifocal lesions. So this is my take-home message. Thank you very much. Sorry for a little longer because I was given the 10 minutes time, but it was not enough to rest this.
Thank you very much, really, for giving the overview. This is not going to be easy job. Thank you very much. Now, can we call the next speaker is Dr.
Thank you.
P.K. Paul. He is going to talk about the association of DNA damage response pathway arsenic in use urinary bladder cancer, the high resolution genomic analysis approach. Dr. Paul, please.
Yes.
May I request you to please stick to your time so that we don't encroach on others' time. Thank you
Sir.
very much.
Sir, good morning. Respected chairpersons, my fellow colleagues. This is a basic research in uro-oncology. This is my topic of presentation. Sir, time is there. Which one is enter? Oh, sorry. it's coming here? Okay. Sir, would you please rectify the time?
Yes, sir.
Time, please. Okay, time, please. Sir, this is our collaborators for this study. This study was conducted, clinical work was done in IPGMA SSKM hospital, and genetic regulation department helped us to do the microarray, and arsenic estimation was done in the Presidency University in the Department of Biological Science. Now, as you know, that developing areas bladder cancer incidence with the mortality is very high, but in country like India, the incidence is gradually also increasing with a mortality of 2.6% with the incidence of 5.3%. Though bladder cancer is an old age specific disease, but recently between the 30 to 40 years age group, we are getting much more patients. In the Southeast Asian countries, last 5 years we are seeing that 21% increase in the bladder cancer incidence. It is one study done in our department published in the Journal of Cancer Research and Therapeutics, where we see that 16.1% patients were presented below 40 years of age group. Now, these areas are our interest. Bladder epithelium or urothelium is divided into 3 parts. Most superficially, there are umbrella cells, followed by differential layer, and basal layers lying the most immature cells. We are concerned with this part of the bladder. We know that this bladder epithelium become insulted by tobacco smoking, aniline dyes, and some other carcinogen. Here, the role of arsenic lies here. As we know that the disease progression model, if there is loss of chromosome 9, bladder cancer develops by any of these carcinogens, leading to this aberration of the chromosome 9. These tumors may be superficial tumor. There may be good survival, recurrence, or multifocal tumor. But in case of loss of chromosome 9, along with retinoblastoma gene or this P53 gene, those who are tumor suppressor gene loss, along with the loss of 6q, 11q, 13q, 18q, and gain of 3p, 5p, 7p, or 12q, disease may grow to muscle progressiveness. This is the genetic progression model of the bladder cancer. In West Bengal, in various districts, as laid down by the Jadavpur University, groundwater arsenic level, we see among 242 patients, among 279 patients, 242 were severely affected districts, 28 were mildly affected districts, and 9 patients were arsenic safe districts. This is a study, age-old study done in Finland, where the authors have shown that incidence of bladder cancer mortality and cancer cancer mortality was high along with the groundwater estimation of arsenic. So we know that arsenic is less important. In case of bladder urine level, what we have also seen that arsenic level in blood and urine was not significant. So arsenic might get accumulated at the site of carcinoma. Here is the groundwater arsenic level, which was evaluated by the School of Environmental Studies in Jadavpur University in all districts, and all districts level where the arsenic level in red arsenic levels is more than 50 microgram per level in drinking water, and arsenic is 11 to 50 microgram per liter. That is permissible level as per World Health Organization. And according to this district level, the data registry, cancer registry shows that the incidence of the disease is also high in various districts of the West Bengal. So our objective of this study was arsenic accumulation, considering the arsenic accumulation within the bladder tissue and its impact on genetic aberration, identification of the chromosomal alteration, preferential caused by arsenic. genetic differences between genetic induced bladder cancer from that without genetic arsenic induced bladder cancer, and identification of the genetic aberration pathways along with molecular, along with validation and validation of that molecular pathway. So if we see the malignant and non-malignant disease of the arsenic in various districts of the West Bengal, where we have plotted as per the arsenic positive and arsenic negative blocks of various districts. So if we see go for the arsenic amount of the, in our primary stage, we conducted the amount of the arsenic estimation in manogram per measure. We did the arsenic determination by atomic absorption spectrometry. As per the recommendation of the EPA, total arsenic level in the soft tissue of unexposed individual might range from 10 to 100 ppb. World Health Organization has not categorized till now any safe level of tissue arsenic level. So our work plan was collected samples all categorized into arsenic high and arsenic low samples. 5 arsenic high and 5 low samples were randomly processed for complete genetic hybridization and single nucleotide polymerization. At first 10 samples were analyzed to find out the frequently altered chromosomal lesions, and 40% penetrance value was taken to find out the amplified regions, and less than 30% penetrance value is considered to find out frequently deleted regions. This data has been submitted in the genetic expression omnibus. This data will be locked there for 2 years. Within 2 years, we have to validate this data, then anybody can present it, work it with it. This is the microarray estimation in SOP. First double stranded DNA was made isolated to single stranded DNA both in tumor and normal tissue. It was labeled with fluorescent dye. Then it was hybridized to amount the much more. It was scanned and it was plotted within the dots. These slides contain thousands of dots encoded with all genotype regions, and when this amplified or fluorescent dyed samples are passed through that region and it was washed, then amplified regions were giving the higher signals and these deleted regions giving the low signals. That signals were determined by the computer and it was assessed which regions were amplified. So if in case of low arsenic sample, if we see the complete genetic database, all the genes are plotted here and there is no much significant deletion or amplification is seen here. But in case of high arsenic samples, we are seeing high amount of significant deletion in all genes. So these are the genes we have find out that these are the significant deletion of the genes in case of high arsenic samples. If we see the interchromosomal deletions, this part of the genes are being deleted. This part of the genes we are seeing the interchromosomal lesion deletion, and if we see the circus plot of both interchromosomal lesion, maximum deletion occurs here. So these are the pathways which are identified, and ultimately 50 significant pathways where p-value is more than 0.005 was identified. We have identified this pathway. We have worked on role of BRCA and DNA damage response pathway. That is the most significant pathway because we know that arsenic causes DNA damage. So these are the genes, these are the chromosomal locations of the genes, and these are the frequency of alterations of the genes. This is the BRCA pathway. Ataxia telangiectasia is related to double-stranded protein, helical protein. When there is any significant deletion, sir, 2 minutes more. When there is significant deletion of that DNA, so this FA complex, that complex is activated, and ultimately it is ubiquitous with T2 protein that form a DNA damage inducible repair foci that causes DNA damage. When there is DNA damage, this D2 gets united with this foci and it causes DNA damage. But in case of DNA damage, in case of this arsenic hampered this pathway. Again, this was validated by this way. We have validated that FNCD2 gene, that is the maximum concentration, and we have seen the significant homozygous and heterozygous deletion here. This is the find out, this linear graph shows that amount of arsenic concentration, this validation or this deletion is much progressed. Again, we have another way we have deleted, we have done this immunohistochemistry analysis to find out the deletion, where we can see in high arsenic samples there is significant low expression of protein. So these are our studies, these are the result of our studies by this BRCA pathway. So our conclusion is that we know that arsenic is a potential clastogen and it causes significant deletion of the part of the chromosome, point mutation of the chromosome, and the changes of DNA double helix to single helix. So Moreover, in our study, it has been shown that large amount of arsenic, large amount of chromosomal lesions are deleted by this arsenic. So that chromosomal lesion might contain the tumor suppressor genes like tumor repairing genes, that is FNCC, FNCM, FNCN2, FNCD2, etc. So deletion of the genes alter this pathway, FABRCA pathway, that might induces the point mutations of the genes, leading to cellular aberrations and more chromomatosis, leading to malignant formation. Thank you, sir.
Really giving us insight into this problem which every one of us faces, but we really don't know the basis of this. Thank you very much.
Thank you, sir.
We go to the next talk by Dr. Pawan Chelsea. He's going to talk about the decade journey of renal transplantation. Dr. Pawan, please.
Well, Dr. Pawan, I just want to tell others that he is the NAUS secretary. He's just taken over the last year. He's a very dynamic secretary of NAUS, and we are also happy that President of NAUS also is here to chair the session. So we are really privileged with your presence of President and Secretary of NAUS. You can go ahead with your talk.
Thank you, Chairpersons. Greetings from Nepal Association of Urological Surgeons. On behalf of Nepal Association of Urological Surgeons, I wish a grand success of this USICON 2019 in Bhubaneswar, Odisha. I am very grateful to the organizer to have these sessions. Actually, we started this from last year USICON at Jaipur, and I hope we will continue this session in the futures too. I am here to share our decade's journey on a renal transplantation at our hospitals, known as Tribhuvan University Teaching Hospital at Kathmandu, Nepal. We all know that the history of the organ transplantation dates back to our mythology. But it took a long way, and only in 65 years back, the first successful kidney transplantation was done by Joseph Murray. And it took us about 54 years to start this successful program at our country, Nepal. And the first successful transplantation was done in our hospital on 8th August 2008. Since then, many other hospitals have also started, and there are about 4-5 centers in the country who are doing this transplantation regularly. We all know that this renal transplantation is a teamwork, and this is a picture showing the first team who has successfully done the transplantations at our hospital. And we are very grateful to the donors. Unless there are donors, these programs cannot be sustainable. Till now, we have already completed 537 living-related transplants. We are also doing AVO incompatibles. We have started pair exchange to suffice the organ needs, and lots of surgical challenges has been done. Donor evaluations with all these pictures are paramount importance before doing the surgeries. Till now, we are only doing open donor nephrectomy by flank approach, open approach, and I'm sure with the help of you all, we'll soon start the laparoscopic donor nephrectomy at our country. And hopefully in the next meeting, we'll come up some data with the laparoscopic donor. These are the few of the pictures showing the transplants. The few demographics that among these 537 patients, most of the recipients were young and the donors are elderly. Usually parents are willing to donate their kidneys. If you see this data, typically the recipients were mainly dominated by the males as compared to the donors. The female dominate the scenario. And we have also done, our choice is the left side, but we have to do in few cases where left side is not suitable, we have to take a right side. We also face lots of complications during our surgical procedures because the complications are inevitable and they are pretty common too. And all the surgeons, we know that the complications come along your pathway. If you see the urological complication in the kidney transplants, they are reported in the literature about 3 to 7%, and most of the centers, they have less than 5%. And these complications are typically have the era effects because if you start, when this kidney transplantation started in 1950, there are lots of complications that happened because of the lack of biological behavior. There are no good immunosuppressant drugs. Now it has significantly reduced up less than 5%. We all know that the biological behavior, we are also knowing the lots of anatomical structures which are very crucial to avoid these complications. If you see the donor nephrectomy procedures, we have very less significant intraoperative complications. There are a few slippage of the renal artery ligatures. There was segmental artery injury during the harvestment, but they all were managed during the intraoperative time. There were minor post-surgical complications were noted, and they are not significant. Until now, all the donors are safe, and they are on a regular follow-up. If you look at the renal transplant complications, they are broadly categorized in the wound or infectious-related complications, vascular, and ureteric. I'll go one by one in detail. About 6.6 to 7% patients have the wound-related complications. These are usually wound-related complications. We know that because of the immunocompromised states and the patient are uremic, they are usually have a high wound-related complications. The vascular complications, pneumonia, and ureteric complications are also common. We had about 4% of vascular complications. When we start the procedures, if you see this, our initial first 300-400 patients, these vascular complications are more on the initial side of our journey, because once you gain the experience and all these microvascular surgical techniques using fine sutures, magnification, these all improve our outcomes. And if you see this data from the various literature, still our complications are comparable to them. This is one of the index cases who had developed the renal artery stenosis and where angioplasty was done with the stenting. The urinary complications like urinary leak and stricture are also there. It's around 2 to 3% complications, and all those were managed successfully. These are few of the representative pictures where when the patient has a leak, we have to put a patience, diversions, do the integrated study, and we are doing most of them were corrected within few weeks' times. Lymphuria and lymphocyl are also still common, and there are in about 2% of cases. In few cases, we have the severe unwanted complication like the graft ruptures that we had encountered in 2 cases, and in both the cases, we could not salvage the kidney. If you look at the mortality, this is a mortality within 30 days of operations. This is a post-operative mortality. Around 14% patient died because of various complications. We are also following these patients extensively, and if we analyze this long-term graft survival in our institutes, this is a 5-year survival that we analyzed 3 years back, and we found that around 82% patients, they have a 5-year graft survivals, and we have already completed a decade and will coming with the results of the 10 years graft survival. This is long-term patient survivals. Still 86% of the patients are still surviving. So I think this is very encouraging for us. Although we started quite late, it's only been 10 years, and many centers are doing it. So now I think the NAUS will take this initiative to start collecting the national data, and most probably will coming with our national data. So to conclude my topics, I'll say that successful kidney transplantation service was started in Nepal at 10 years back, and it's continuing, and now all the various, many centers are doing it regularly. The female dominates the donor pool, while the male dominates the recipients. It's same as in India, because there are lots of gender biases are there, and female are willing to donate. The few complications are inevitable in the surgeries, I know, but the prompt diagnosis and intervention is mandatory. So, our complication rates as compared to the series are quite comparable. Thank you. And I would like to invite most of our USI members to our beautiful country in our 5th annual conference of Nepal Association of Urological Surgeons, which is going to be held in Pokhara, Nepal on February 21st to 23rd. Thank you, sir.
Thank you, Dr. Kaman. I think you have finished your talk very much in time, and we can take 1 or 2 questions from the audience. Is there any?
I want to ask you that in urinary leak, what is your protocol of managing? Whenever you get urinary leak, you diagnose say on 3rd or 4th day. What is your protocol of approach? Would you put PCN in all the cases, or you explore? What is your approach?
Sir, invariably we put all the patient with DJ stent, because in our hospital, when we are doing ureteroneocystostomy, we put a DJ stent. So usually we are not getting a urinary leak within few days time. It has happened without urinary leak. If it's happened within 1 week time, we'll immediately go and re-explore the cases, because there might be this obvious surgical technical failure might be there. But all the patients, and we remove the disease stain after 10 days of the operation because we don't want to keep it longer. So most of this urinary leak, we found it after a few weeks time. So in those cases, we don't explore. We divert the urine. We'll wait for 6 weeks, do the antegrade study, and then decide. Thank you.
Yes, now the next speaker is Dr. Anil Shrestha. He is going to talk on advances in the laser lithotripsy. Is Dr. Anil Shrestha? Yes, please.
Thank you, chairpersons. I would like to thank NAUS and USI for giving me this opportunity to talk on advances in laser lithotripsy in beautiful city of Bhubaneswar. Good morning to you all. The main purpose of my talk is to highlight how the laser has changed in last few decades and what are the new issues are coming up with laser lithotripsy. So as we all know, a laser is there in urology for more than 50 years now. First laser was used in 1968 to treat a case of penile cancer by Ruby laser. Later, only in 1988, the laser was used for lithotripsy, and it's been already more than 30 years now we are using laser for lithotripsy. And holmium-YAG laser was introduced in 1992. Since then, lots of changes and new technologies in laser has come up, and it has helped us to treat our patients more efficiently and safely. So holmium-YAG laser is still considered as a standard of lithotripsy till date because it's more versatile. It can treat all types of stones. It's a solid-state pulse laser with a wavelength of 2140. That's why it's applicable both for stones and soft tissues, including laser and strictures. That's why it's very popular among urologists. So what advances has been made in holmium-YAG laser? The advances made are in two directions. One is in power. Earlier, what was the concept is the first stone, only low power laser was enough. I don't say it's incorrect, but when you have high power laser to treat a stone, you have that liberty of changing the frequency and going down the energy, and you can dust the stone more efficiently. So the power has been increased in recent few years. The shift from low to high and very high, like 120 watt laser has been made. That's why we can run the laser up to 80 hertz frequency. Another achievement or another advances in holmium-YAG is the change in pulse. In very first holmium-YAG laser machines, the pulse duration or pulse width was fixed. It was around 350 microseconds, but in recent years, there are laser machines with variable pulse width. And recently, there are machines with pulse modulations called MOSES technology from Luminous. So as we all know, when we talk about laser lithotripsy, there are three factors: pulse duration, energy, and frequency that comes into actions for effective lithotripsy. So how laser has changed? The initially standard short pulse mode were very popular. Now high frequency, then long pulse lithotripsy. Now in 2016, a group of people from Europe has put forward the concept of burst lithotripsy, but it's not in clinical use yet. So what is pulse duration? Because there are lots of variation, lots of advances in pulse duration. So I just want to highlight few seconds in pulse duration. Pulse duration is the time in which given single pulse energy is delivered, and it's usually measured in a microsecond. Newer laser have this variable pulse settings, and I personally think it's a very important parameter to achieve good pulverization of renal stones. And it definitely helps in reducing retropulsion and achieving good dusting. But ablation, few papers have, few studies have shown that ablative efficiency with short and long pulse are similar. So a new concept of pop dusting has been put forward by urologist from Michigan, Dr. Hani. Pop dusting can be achieved by high power laser with 120 watt laser. I personally think it's a fast popcorning. When you have the lower power like 0.5 joule with 50 to 80 hertz of energy, and when you use short pulse. You can achieve same effect of popcorning very fast with pop dusting. The time of popcorning will be reduced. So another advancement in laser technology is a MOSES technology. It's a change in pulse. It's a dual pulse model of lithotripsy. When the first pulse splits the water vapor, it's a vapor, and second pulse is delivered to the targeted stone or the tissue more efficiently. So the energy transmission is more optimized with MOSES technology. So this is a small clip that is used to dust the stone. You can see the stone is being melted. It's very nicely dusted. The stone is, the laser is a few millimeter, 1 or 2 millimeter away from the stone, and you can see the very fine stone, fine dust that is created by MOSES, and the duration is also very, very fast, and you can achieve a very fine dust with high power MOSES technology. So the recent study from Europe has compared the characteristics of dust that is been made with or without MOSES laser lithotripsy, and they have concluded that with MOSES lithotripsy, the changes in lithotripsy, the end result of this dust are more pronounced. It makes more finer dust, and the lithotripsy is more efficient, and it's published recently in October 2018. So to conclude, MOSES is a modulated pulse technology. It has to be delivered by a special kind of DFL fiber. It's a ball tip single-use fiber, and it helps in less retropulsion by making more control and probably a better dusting. So another advancement that has been made in laser is a Trillium fiber laser, TFL. It's a latest laser technology. It's a promising alternative of holmium YAG laser, and it's not as same as solid-state laser or holmium or another YAG laser. So it's basically the medium is doped in the fiber itself, and the fiber laser doped with the thulium is called TFL. And it is in early experimental studies and early clinical studies, it has produced very efficient lithotripsy, and it is seemed to be 2 to 4 times more efficient than standard holmium YAG laser. So just to compare the available holmium YAG laser and TFL, thulium fiber laser, it's not thulium YAG laser, it's a thulium fiber laser. They are more compact. You can see on the left side of the picture, there is a small laser machine which is tabletop type, and the bulky holmium YAG laser, but the power is very high with thulium. It can go up to 500 watt, and the maximum frequency we can achieve to 2000 hertz. But for clinical use, it is advised to use only up to 500 hertz. It's a different system. It's air-cooled. In comparison to holmium, it's a water-cooled, and it's the ablative efficiency is very high. So to conclude, laser technology is one of the youngest technology in urology, but it's constantly changing. To make laser lithotripsy more safer, faster, and efficiently, the technology is changing very constantly. And holmium YAG is still considered as the gold standard, but thulium fiber laser can be a promising alternative. Thank you.
Thank you, Dr. Anil, for talking on this one-season laser lithotripsy. Well, you did mention this thulium fiber laser, its application
Yes, sir. But I have seen few friends from India. They are using TFL in India. I totally agree that it's not been approved by FDA, but it's still in the very early clinical phase. So there are no proved data.
Yeah.
Yes.
One cannot cite anything which is not in the report.
Yes,
There
yes.
has to be evidence-based.
Sure, sir.
We do so many things. It doesn't mean that we take cognizance of those
Sure.
things. But the thing is, we have to wait for its really evidence. It has found its place in the clinical practice, in the research lab, and only then probably will come to the market with that authentication.
Yes, sir.
Thank you very much.
Thank you, sir.
Now we move on to the next topic by Dr. Mahesh Adhikari, shockwave lithotripsy. I don't know if it is written, is it on deathbed? I don't know. Is it living or is dead? It's deathbed. Let us see what he has to talk about this. Dr. Mahesh.
Good morning, respected chairpersons and fellow colleagues from all over the world. So this is after a very good presentation by Dr. Anil Shrestha about laser. It's very difficult to justify ESWL nowadays. So there are different modalities of the management of the renal calculus. Among them, shockwave lithotripsy is still an option. So nothing can be very ideal, you know. So this is a heavenly picture of one of the place in Nepal, Namche Bazar, base of the Everest. And it cannot be, anything cannot be as ideal as that photo, you know. It's a very heavenly photo. So none of our treatment modalities for renal calculus is ideal. So there are many new procedures coming up, but they can't have all these parameters available with all the procedures. I agree that there are trends in, the trend of ESWL is going down and the trend of flexible URS is coming up, whereas the PCNL has been stationary for the last 10 years. There are many reports suggesting that flexible URS or RIRS is much better than ESWL in many, results, you know, they are very result-oriented. They have many advantages of the shockwave lithotripsy. I also agree that, but if you remember, you know, if you have 7 mm stone, 8 mm stone, 9 mm stone, people are doing a lot of RIRS, which can be easily managed with shockwave lithotripsy. So there are reports, this is a Sukra curve. Anything below that, the area under the curve is significant. So the stone, as this graph suggests, the stone-free rate and the auxiliary procedures are definitely high with ESWL. The rest of the parameters are actually in favor with the shockwave lithotripsy. So the other results also shows that the stone-free rate and the retreatment rate are actually higher in shockwave lithotripsy. Rest of the parameters are actually better with the shockwave lithotripsy. But I come from a country where Buddha was burned. You have opportunities and you have hopes in all the modalities of treatment. So UAE guideline also, there is a scope for shockwave lithotripsy between 1 and 2 centimeter stones. Even lower pole stones also, there is a role of shockwave lithotripsy when the anatomy is favorable. And EAV also recommends, this is one of the favorite treatment modality in a pediatric subgroup. So why still shockwave is an option? So it's the least morbidity procedures. It can be done on OPD basis, no need for anesthesia, hospital admission, and least expensive procedure for the patient, especially for countries like Nepal and India. We need to actually take care of the patient's expense also. So good results if you select the patients properly. So I work in it's a private setup, Nepal Medicity Hospital. We have a good Dornier machines which can be operated both by the fluoroscopy and the ultrasound guided. So there has been a lot changes, development in the shockwave lithotripsy modalities, but nothing can be compared with the original HM3 shockwave lithotripsy in terms of efficacy. Although the new machines are
very patient-friendly and safe, but the efficacy cannot be compared with the original one. So in our experience in last 1 year, so we do many PCNLs, RIRS, and patients who are actually eligible for ESWL, we counsel them about the ESWL. We counsel them about the failure of the procedure, counsel them about the need of multiple sessions or the auxiliary procedures. So after counseling, only 64% patient, the 55 patient agreed for ESWL. So most of the stones were less than 10 nm, and the stone locations were basically renal pelvis, mid pole, and the lower pole. So the lithotripsy is basically done by us only, urologist and the urology nurses, and all the preparations are done according to the protocols. Our success, we define success as any fragments less than 4 millimeter, residual fragments of 4 millimeter, or no need for any auxiliary procedures. So the overall success rate was 76%. If you see stone, Huntsville unit less than 1,000, the overall success is as good as 81%, and for more than 1,000 HU, it is around 58%. So in terms of sessions, the first session, the overall success is 45%, which is higher in less than 1,000 HU, and second session, 67%, and by third session, it is 76%. Success in all locations of the stones are actually similar, no significant difference. So auxiliary procedures were needed in, disease stenting was needed in 5 patients, URS has to be done in 3 patients, and 2 patients needed RIRS. Actually, this patient did not wait for the second session, so we had to do RIRS. So 2 patients defaulted from our regular follow-up. Not only the ESWL has a retreatment, the other procedures like PCNL, RIRS also need retreatment sometimes, and shockwave lithotripsy then can be a head-saving procedure for the urologist. So our complications are fever, 3 patients had fever, ureteric colic in 5 patients, and subcapsular hematoma. This is the first time I've ever experienced a subcapsular hematoma in last 15 years, where I was involved in more than 1,000 cases of ESWL. So which patient to go shockwave lithotripsy? Actually, there is a triple D score. One is dimension less than 1.8 microliters. Second is distance, skin to stone distance less than 12 centimeters, and the stone density less than 600. If you have 3 components present, then the success rate is as high as 96%. And this is another study that if you have a less than 900 HU and less than 9 millimeter skin to stone distance, the success rate can be as high as 91%. And for ureteric stone also, the results are similar. So if you see the radiation exposure, you compare with other procedures like PCNL and RIRS, definitely ESWL has a less radiation exposure than the other procedures. So what is dragging this shockwave lithotripsy to its deathbed? Because of the stone-free rate or need for auxiliary procedures. And it's many times difficult to actually predict which stone is going to be fragmented. So needs some development to improve the outcome of ESWLs, including navigation system and the stone fixation systems. So in my conclusion, it is a time-tested procedure. It is a non-invasive and well-tolerated procedures. That's why ESWL is still a viable option for properly selected patients. So thank you, and welcome to Eurocon 2019 in Pokhara, Kathmandu. So, thank you, Dr. Mahesh. So, you ultimately know finding that shockwave lithotripsy still has got its role in a very select group of patients.
Yes, sir.
So, that's fine. I'm not very happy with your this caption of USICON does that, because it's not on deathbed, but it is still got its role.
Yeah.
In those scenarios. Thank you very
Thanks.
much. Thank you very much.
Thanks, sir.
We move on to the next topic, the talk by Dr. Bladder. Hello, is any change? Oh, you are there. Surviving from sepsis in endourological stone management. I think this is a very common scenario, and some of the patients, those who really slip into the sepsis following this procedure, it is a nightmare. Let's see what he has to suggest or talk about this particular management.
I think better to switch off the time because source is. Respected chairpersons, professors, colleagues, and delegates, a very good morning to you all. My topic of presentation is surviving sepsis in endourological management of nephrolithiasis. Basic objective of my presentation is about to highlight the problem, and there is lots of change in definition of the sepsis itself by 2018 now. Preventive measures and early detection and management strategies. It is a sort of micro-teaching rather than some data presentation. So as all of us know that RIRS and PCNL are the most common minimally invasive procedures in neurology, but they are not immune from complications like morbidity and up to mortality also. If you go to the Cross Global Study 2015, fever incidence is 10.5%, but sepsis and mortality is very few out of this almost 5,000 patients data. In another study, the incidence of SIRS following RIRS is around 9%, and severe sepsis in 3% patients, and in PCNL patients, it ranges between somewhere in 7% sepsis. What is the main issue of managing the urosepsis is that mortality and morbidity is very bad, and second is the financial toxicity, as all of us know, in the resource-poor countries like ours. So mortality out of 1,000 PCNL, 4 died due to sepsis, this is international data, and in RIRS also now cases are coming up, 6 case reports are there from different centers. Literature is there. So what are the challenges of detecting sepsis after PCNL or RIRS is that, particularly in PCNL, the septic shock may be compounded with hypovolemia that we should be knowing. And post-RIRS shock is septic unless proved otherwise. And we work on suspicion only because urine and blood cultures, it takes 48 hours to come based on the culture sensitivity report. Are there any markers to look for that for sepsis? Of course, arterial blood organ analysis with lactate is one of the markers. Procalcitonin not easily available everywhere, and it's expensive also. And recent addition to this cart is the mid-regional proadrenomedullin is coming up, new marker is coming up. But clinical judgment is always important because oliguria, metabolic acidosis, respiratory alkalosis, these are the clinical judgments that we can see on the bedside very early, then the markers, they help us to manage the early recognition and management. We do the RIRS and PCNL, patient has fever, many of the patients have fever, around 10-20% of the patients. Which fever is significant that we should know? Fever associated with HAT are dangerous. If a patient is wearing hat, then think of that, it's going to burn here. Because hypotension, then altered sensorium and tachypnea. Out of that, most subtle finding on the clinical judgment is tachypnea, hyperventilation. Fever with hyperventilation is dangerous. We have to work on sepsis in this subgroup of the patients. Risk factors for urosepsis in endourology, all of us know in PCNL, strobitis stones more common, long operative time,
more than 90 minutes, and high intrapelvic pressure crossing 20 or 30 millimeter of mercury is dangerous. In RIRS also same principle applies. So can we predict sepsis related to the PCNL in PCNL or RIRS so that we can act on prevention, early detection, and management? So there are few predictors of preoperative predictors of SIRS in sepsis or in urology. They are high sensitivity C-reactive protein. Most of the centers have standard CRP level measurement, but high sensitivity CRP, high sensitivity CRP albumin ratio, and neutrophil lymphocyte ratio. These are the basic area where we can do research in the coming days. Intraoperatively, pelvic urine and stone cultures, these are the predictors well given in the literature. Now coming to the changing definition of the sepsis, there is change in the definition of the sepsis. Previously, sepsis was culture positivity along with SIRS, but now that has been changed. They have taken to the SOFA scoring system, sequential organ failure assessment, and sepsis, the new definition is that suspected infection along with equal or more than 2 SOFA score. That is basically some arterial blood organs analysis finding, then blood investigations, then creatinine level, clinical judgment, GCS, and blood pressure based on these SOFA systems is coming. This is from third sepsis 3 consensus guideline, 2016. Severe sepsis was the previous term. Now that has been removed in 2016 now. Now new system has only either sepsis or septic shock. In the septic shock also definition is changing. They are more focusing on persistent sepsis with persistent hypotension, requiring vasopressors to maintain MAP of more than 65 millimeter of mercury. Along with that, marker of the tissue hypoperfusion, that is increased lactate level. So to screen for sepsis, quick SOFA scoring system is there, that is HAT, hypotension, altered sensorium, and tachypnea. If 2 or more than 2 findings are there, then you have to work on organ failure assessment and along with resuscitation sidewise. SIRS, systemic inflammatory response syndrome, that is now historical one, but still it is valid as an early warning for sepsis. So organ dysfunction in SOFA score, I don't want to go in detail. So how to prevent urosepsis in urology? First and foremost is the aseptic techniques, general measures are there. Antibiotic prophylaxis, well established for, strong recommendation is there for PCNL, but for RIRS and flexible URS, weak evidence is there, still we recommend. Along with that, we have to operate always on patients with sterile urine. In RIRS, always try to use the urethral exercise as far as possible. Always irrigate with caution, checking the continuous outflow of the urine, and do not exceed the operating time of more than 2 hours. 90 minutes we talk more often. Then carefully monitor patients in the postoperative phase. These are the one. And early detection system-wise, again, this quick SOFA scoring system is there that we have to apply. Management of urosepsis, it's lactate changing therapy, then culture, microbiology, all those things are there. I don't want to go in detail. Most important is vasopressor and vasopressor application timely and source control. Surviving sepsis 2018 guidelines highlights that you have to do it very, very early. Previously, it was 6-hour bundle. It has been reduced to 1-hour bundle. As far as possible, if you do, even then it takes 3 hours to complete this bundle. So blood culture, of course, 2 sets. Urine culture, we sent. Then which antibiotic to give? If you think multi-resistant organism, you go for combination. If not, then you go for single. Most of the post-procedures are multi-resistant pathogens are there. Role of the urologist in source control is very important. Catheter removal or exchange, stent removal, decompression, infected items, then PCN placement or drainage, these we have to do in warp footing. So to come to the summary, now in 2019, to diagnose sepsis, SIRS is no more valid because for proper reporting and standardized reporting, we need to switch to SOFA system. And then early goal-directed therapy, 6 hours bundle has been reduced to 1-hour bundle. And empirical antibiotic, of course, at the beginning, followed by, guided by the culture sensitivity report, we have to go, and source localization and source control is of paramount importance to survive urosepsis in urological procedures. Thank you very much. Any questions are heartily welcome. Thank you, sir.
Thank you, Dr. Bordar. I think you have given your message very clearly that one has to recognize this problem at the earliest. In fact, you should not wait for all these things to happen. You have to take a preemptive measure and treat this patient preemptively. Otherwise, if they slip into septicemia, then you will probably
sir.
Thank you very much for giving this message. And we move on to the next
Thank you, sir.
talk by Dr. Manish Pradhan. Dr. Robin, yes. He's going to talk on the PCNL in patient with post-open renal surgery. Yes, Dr. Robin, best name.
Honorable chairpersons, distinguished guests, colleagues, warm greetings from Nepal. I'm going to talk about one of the studies done in our department, outcomes of PCNL in patients who had a history of open stone surgery. We all know the prevalence of nephrolithiasis is globally, has been reported in various literatures, 1 to 15%, and there is increase in the incidence, which could be due to our lifestyle mode changes. So there could be actual increase in the incidence, or due to the improvement in diagnosis, there could be increased detection of asymptomatic stones. We also know that the recurrence of this nephrolithiasis is a recurrent problem with recurrence of up to 50% within 5 to 10 years. And more in patients who have history of, who have family history of stones, uric acid stones, residual stones after previous surgery which have increased in size, or growth of insignificant residual stones. PCNL was introduced in 1976, and in our part of the world, still, it's a new, in many parts of our world, it's still a new armamentarium, and those patients who had a history of open surgery in the past, who have recurrence of the stones, they come to PCNL to us because it's cost-effective, lower morbidity, so, because of shorter operative time and lower post-operative complications. So we did this study in our department. After obtaining ethical clearance from the subject committee and IRB, it was a prospective observational study conducted in between April 2015 to March 2018, 3 years. Informed consent were taken from all patients. On admission, demographic parameters were recorded for all, routine investigations were sent, and all the patients who had CT urography with stone density measured in the unenhanced film. For those patients with recurrent stones, we also did an abbreviated metabolic analysis. All PCNL were done either under general or spinal anesthesia in prone position. Transpapillary punctures were done under fluoroscopic guidance and were done under fluoroscopic guidance after retrograde opacification of the pelvic calyceal system. The tract dilatation were either single shot or serial telescopic dilatation according to the decision of the operating consultant. Single or multiple tracks were used. For all these patients, we used 21 French rigid nephroscope. For the large stones, they were either fragmented with laser or pneumatic lithotripter, and these fragments were removed either with continuous low pressure normal saline irrigation or with forceps. Exit strategy could be total tubeless or standard. Post-operatively, they were managed accordingly, and they were followed up in 2 weeks and 4 weeks with X-ray KUB. Complications were categorized according to the modified Clavin-Dindo classification, and we analyzed our data. The results of our data are, in these last 3 years, we had a total of 549 PCNL, out of which 414 patients had a history of open surgery. 84 patients had a history of open surgery in the past, and 414 were primary. We had to exclude 51 patients because in our institute, we rarely deal with pediatric patients. Some patients did not have preoperative CT scan. 3 patients had to have bilateral procedures. We excluded all patients who underwent supine PCNL or puncture under USA guidance because those are in early phase in our institute. For patients whom we had to convert to open procedures, and then for whom we had to treat concurrent ureteral stones. So coming to the demographic variables, we can see in these 2 columns that for patients with primary PCNL and patients who had undergone history of open surgery in the past, the demographic variables are comparable. They are comparable. The stone variables are also comparable, and in intraoperative outcome, we compared the number of tracts used. We can see from this that in patients who had undergone history of open surgery, it was only, by percentage, it was only slightly more than those patients who were undergoing primary PCNL, but it was statistically insignificant, and operative time was almost the same in both the categories. Now coming to the exit strategy, although nephrostomy tube had to be used quite more in the patients who had history of open surgery, but exit strategy was also statistically insignificant. The number of hospital stays was statistically insignificant, most of the patients being discharged on the 3rd postoperative day. Stone-free status, our overall stone-free status, which we defined as either there was fluoroscopic clearance or there was no residual stones less than 4 millimeter at 4 weeks of follow-up. Our total was 83.13%, out of which in both the groups it was comparable. Now coming to the complications also. When we concluded the study at the end of 3 years, we found that the complications were insignificant, and which is almost all the data, they are similar from midterm analysis and on the conclusion of the study. But in the midterm, we had more complications in patients who had undergone history of open surgery. And if we divide them into Clavin scoring system, they are also similar. But in our midterm, the minor complications, Clavin 1 and Clavin 2, were more in patients who had undergone open surgery in the past. So these are the, in these 4 charts, I have divided the complications according to the Clavin system. Now coming to the conclusion, I can say that PCNL is equally effective and safe in patients who have had a history of open surgery. And in PCNL itself, high-grade complications are rare, and so in the patients with history of open surgery. But I recommend further multi-institutional studies. Thank you very much.
Thank you, Dr. Robin. When I studied, what was the aim and objective of this study? What is the other way options you are thinking of in these patients? If they undergone a surgery, fine. That was the era. But now, what was in your mind? What was your aim and objective?
In our mind, before we conducted this study, we thought that those patients in whom they have undergone open surgery in the past, it will be difficult to even puncture the patients due to the fibrosis in the scar, due to the sutures, and then the like.
But you did not mention any such technique that there was a difference in technique of the puncture.
There was no difference at all. There was no difference at all. There was no difference.
There is no difference at all in that regard.
There was no difference.
Fine. Thank you very much.
Thanks.
Any questions from the audience? Any questions from the audience? Thank you. Well, we now move on to the monopolar versus bipolar TRBT, a randomized controlled study by Dr. Manish Pradhan. Dr. Manish.
Thank you, sir. Respected Chairperson, my seniors and our colleagues, I'll be presenting on bipolar versus monopolar transjudicial resection of bladder tumor, a randomized controlled trial done at our institute at TU Teaching Hospital. I am Kathmandu, Nepal. As you all know, bladder cancer is a common malignancy of urinary tract. It happens to be the 9th most common cancer overall in the world, and in Nepal it is 7th most common cancer. TURBT has been the standard treatment for non-muscle invasive bladder carcinoma. Specifically, the monopolar system has stood the test of time, which not only confirms the diagnosis but also helps to remove the tumor. The basic difference between these two systems is in how the current circuit is completed, which is longer in monopolar system. The energy and voltage requirement, which is again higher in this system, hence greater heat is generated, causing desiccation of the tissue. However, in the bipolar system, it uses a plasma to efficiently cut the tissue, and also we can use the isotonic fluid for the procedure. So at least in theory, bipolar system seems to be better. So what's the use of this study? So the rationale of our study was that because conflicting results have been reported for bipolar as well as monopolar TURBT. Earlier studies had shown better outcome with bipolar system. However, later studies had failed to prove its superiority. Only few systemic analyses are available to draw the conclusion. So we wanted to study the safety and efficacy of these modalities in our population. So with the objective to compare the safety and efficacy of bipolar and monopolar TURBT, we had a primary objective to compare the incidence of obturated shock in monopolar and bipolar TURBT, and these were our secondary objectives. So this was a single center, single blind, parallel arm randomized control trial done at TU Teaching Hospital over the period of 1 year. Allocation was done in 1:1 ratio, and approval was taken from our institutional review board. All the patients undergoing TURBT for suspected bladder carcinoma under spinal anesthesia were included, and diagnosis was based on either imaging or cystoscopy done prior. Those patients who declined to participate in the study or those who did not have tumor in the lateral wall were excluded, as our primary objective was to study the obturated shock. Coming to the technique, all the patients were done in spinal anesthesia and determined position. Karlsruhe's research scope was used, 30-degree telescope. For monopolar system, we used a Covidien Valley Lab generator, and for bipolar, BOARC 400 was used. This is the result. There were a total of 118 eligible cases. However, 36 were excluded as they did not have a tumor in the wall, lateral wall. 6 were not fit for spinal anesthesia. So we ended up with 82 patients in each group, 41. However, there was 5 protocol violation in the monopolar arm and 7 in bipolar arm. There were no patient lost to follow-up. So we ended up with 36 patients in monopolar and 34 patients in the bipolar arm who could be analyzed. This was the basic demographic variable. As you can see, both the groups were comparable in regards to age, the sex distribution, and the size of the tumor in the bladder. The primary aim, the objective, the obturated shock was numerically higher in the monopolar arm as compared to the bipolar arm, but this was not statistically significant. As regards to bladder perforation, sodium drop, they were similar. Hemoglobin drop, although statistically significant, it was not clinically significant as there was no difference in post-op outcome or transfusion requirement. The resection time was statistically less in bipolar arm. However, the duration of post-op hospital stay, the rate of detrital muscle identification, and the severe artifact defined as more than 50% artifact in the histopathology tissue were not different in these two groups. Coming to the discussion, as we all know, monopolar system is a gold standard for TURBT, but many complications have been reported, with earlier studies indicating many advantages of bipolar system as regards to operating time, the less obturated shock, bladder perforation, transfusion requirement. However, very few randomized control trials are available to compare these two modalities. Sorry for the busy slide, but here I want to show how the trend of reporting has changed over the year. The earlier studies from China and Romania had favored bipolar arm group as regards to less obturated shock and bladder perforation. However, from study from India, CMC Vellore in 2013 had shown no difference as regards to bipolar or monopolar in these two variables. In 2015, this study from Turkey actually showed bipolar group had more obturated shock and more bladder perforation, and our study did not find any difference between these two variables. As regards to resisting time, earlier study has shown no difference. However, we found that monopolar had efficient cutting, and so less time was needed to carry out the procedure. The hemoglobin drop, although significantly different in our study, was not clinically significant. And as regards to Cotry artifact, the study from India has shown better results with bipolar, but we did not find that results. So let's see what the meta-analysis says. Again, there's very few data to draw the conclusion. This meta-analysis from Yuchu et al. Had a problem of having only 4 RCT, 3 case control trial, and 1 cohort trial. But still, as our results, they had shown that there are less restriction time in bipolar, less post-operative catheterization time. The hemoglobin drop was also significantly less. However, transfusion requirement was not different. The arbitrary nerve reflex was also not different, and bladder perforation rate were also not different. So to conclude, I would like to say that bipolar TURBT is as safe as an efficient alternative for a monopolar TURBT. Bipolar TURBT is associated with decreased restriction time and hemoglobin changes. However, there is no difference in two modalities as regards to operated jog, bladder perforation, transfusion requirement, and severe artifact. Thank you.
Thank you, Dr. Manish, for talking on this topic which has been very hotly discussed since last decade, and people are giving all these conflicting reports. But one thing is certain, that it was only a myth initially that it doesn't cause this and this, but ultimately to see the reality doesn't make much difference. In fact, the only drawback which we find with the bipolar, and we have published also results recently from AIMS New Delhi regarding this, was the only that artifact. Our pathologists, they were very comfortable in reporting the histopathology specimen with the bipolar rather than with the monopolar. There are less artifact. Rest, there were no difference clinically or intraoperatively otherwise as regard results, bleeding, and the time. Rest is almost the same. So thank you very much. And I'd like to have, I think from the audience, we need to have some involvement. This is the first session, the first day, and I don't find people have, I hope they have a lot of energy and questions. They have come already prepared, they have done their homework. So I want some questions from the audience, especially from the younger block. These days there is a trend, this people will lay more emphasis on the interactive, but people do not participate in this interactive session because they have done so much homework to prepare these presentations. And if there are no questions, probably they will also feel that we have presented, but the takers, they are not understood or there is some problem. So for that sake also, to encourage the speaker, we should have one or two questions. Can we have? Yes, please. Yes, there is. Can somebody give the mic? Please identify yourself, the institution or hospital where from you are, and then ask the question. Okay.
Sir, good morning, sir. I am Dr. Karthik Sridhar. I am a specialist in urology from Babasaheb Ambedkar Hospital in Delhi. You said that you have done all your cases under spinal anesthesia.
Yes.
So in the monopolar group, did you give an obturator block before the surgery?
No, that would have been the compounding effect. If those who had previous resection and reflexes previously recorded, those were automatically excluded from the study as they would have not been fit for only spinal anesthesia.
Sir, thank you.
Yes, please. Go to the mic.
Dr. Etkal from Bangalore. Did you come across any strictures in these cases?
Sorry, sir, I didn't get it.
Stricture urethra.
Strictures. Strictures
Yeah,
post-operatively.
Right.
So yes, we do find during our check cystoscopy. Yes, it's
Which was more in monopolar or bipolar?
although this was not a part of our study, but
as
in
incident
part of
check.
our follow-up, yes, we find more in monopolar arms. Sir.
Actually, the earlier study said that this stricture is more in a bipolar.
Bipolar.
Now the industries have taken care of that. It was a misconception, again, a myth, that the current goes through the sheath and causes burning.
Yes, sir. There was a quasi-bipolar machine in our institute as well.
That thing has been taken
Yes, that is taken care now.
Thank you very much.
Thank you, sir.
You have done your best. Now the next is Dr. Prakash Shetty. He is going to talk. He is not there. So we have the last batsman is Dr. Miyapan, our great Dr. R.N. Miyapan. He is going to talk on the Trump and the challenges in the renal transplantation, Indian perspective.
Thank,
Dr. Miyapan.
thank you, Mr. Chairman, for giving me this opportunity to share the views of triumphs and challenges in renal transplantation, Indian perspective. I have come as the last tailender. It's a chronic kidney disease, a devastating clinical disease, a vast social, economic, and ethnic complications. It is a silent epidemic. If you could see this map, this is not a geographical distribution of the map. You can see the incidence of CKD is so far in India. When you compare in Australia or New Zealand or in North America, you could see this depiction of an altered geographical distribution of the magnitude of the CKD. The CKD prevalence, now we will focus on the global, then we will go to the India, then we will go to the state where I am being as a urologist for 3 decades. The incidence of CKD in world population, if you compare China with India, you can see the nearly about 28 lakhs and 976 men or the people are in CKD. If you take the analysis, the CKD burden in India, North India is 785 per million population. In South India, it is 870. Central India, it is around 151. And nearly about 2 lakh people develop ESRD or CKD annually. This is a tip of the iceberg. You could see all these symptoms, but the AKI or the CKD is going to be the big phenomenon in iceberg or this thing. The options are available for this CKD patients: peritoneal dialysis, hemodialysis, of course, renal transplantation, whether it is related or unrelated, and disease donor transplantation. The neo techniques, the domiciliary or CAPD or nanotechnology. Why transplant? It is treatment of choice, improved quality of life, prolonged survival, free of dialysis and dietary constraints, improvements in anemia and bone disease. It is cheaper. Renal transplant in India, in 1965, is the first cadaver transplant in Mumbai. 71, renal transplant in Vellore. Maharashtra Kidney Transplantation Act was introduced in 1982. The Transplantation of Human Organs Act was introduced in 1994 by the Government of India. In 1996, the first deceased transplant was done in Tamil Nadu in Madras Medical College. And the Government of Tamil Nadu modified the rules of deceased donor transplantation in 2008. There is an illegal organ trade took its toll in government restrictions so that the gap widened. That is, the demand was more and the supply was less. The emphasis of organ donation was done, and you could see in Spain nearly about 32 cadaveric donors per million population, where in India it 0.05. The Indian statistics, the current organ donation for deceased donor is 0.3 million population. If it is 1 per million donation, the rate would have been 1,100 organ donors, which means 2,200 kidneys, 1,100 hearts, 1,100 livers from every cadaver donor, and this should take care of almost all current demands of organs. If you take the Indian scenario, these are the states where the states are with deceased donor activity is more being done. If you see this graph, the kidney transplant has risen from the 2012 to 2015, whereas you could see the other organs also slowly rising up because of the disease cadaver transplant. In the national disease donor transplantation, Tamil Nadu stands first in 2016 analysis. In Tamil Nadu, 32 districts, the population is around 7.7 crores. The centers approved for transplantation is 103. Hemodialysis in almost all the medical college hospitals and district headquarters hospitals, and qualified nephrologists in 18 medical colleges. The first cadaver transplant was in 1996, but there was a lack of momentum. Few institutions were doing it. Lack of awareness among public and medical professionals, no coordinating body, no governing rules. But in 2008, Tamil Nadu government initiated the formal disease donor transplantation. The guidelines by the advisory committee, the rules were modified in 2008. The government orders for the state are also introduced in 2008. What are the initiatives by the government? A series of government orders to provide a boost to the program, to ensure transparency, to streamline the procedure, to coordinate the public and private institutions. The database prioritization lists each hospital for all government hospitals combined, private hospitals combined, and government and private hospitals combined. What are the practical steps which are being followed by the centers? Brain death identification and certification, information to the convener or the member of this team, allocation of the organ based on the set rules, and various NGOs, that is non-government organization, assist the convener in task or organ allocation, maximum organ use. Now, the Transplant Authority of Tamil Nadu has been introduced in 2014, and the chairman is Honorable Chief Minister, and member secretary is senior medical professional. What are the unique features in government of Tamil Nadu? Free of charges for the underprivileged, pre-transplant workup and dialysis, post-transplant of immunosuppressives of lifeline follow-up. The hemodialysis, free of charges, CAPD, renal transplantation, even in empaneled private hospitals. Active transplant centers are 31, government centers are 8, and private hospitals is 23. If you take down the history of immunosuppressive, in 87 and to 98 was steroids and azathioprine, 99 cyclosporin, 2007 in tacrolimus, MMF in 2008, in 2011 besiliximab and recombinant ATG. This is a paper, this cyclosporin withdrawal leading to the delayed graft function. So if you allocate the central procurement of the immunosuppressives, the current annual budget is in Tamil Nadu is around 1.65 crores. Then the cost of the tacrolimus will come around to 5 rupees and MMF will come around 10 rupees. Another major development is the government order for provision of free immunosuppressive lifelong for those who underwent transplant in private hospitals too in Tamil Nadu. What are surgical challenges? It is an emergency procedure, donor not fully evaluated, unexpected situations, and surgical team is prepared to meet the eventualities. This is a interesting case where we did the deceased donor transplantation. The donor had a space occupying lesion. We removed it. Fortunately, it came as a benign lesion. This case report was published in our IJU. In another case, a daughter, following the trauma, she donated after the brain death, both the kidneys were transplanted by her own father, who was a known case of CKD. Challenges, the government problem, no funding for the program, hospital problem, no efforts to identify or maintain the brain dead donors, the community problem, no awareness of the brain death concept. To increase the availability of the donor organs, current organ donation rate mismatch with the brain death statistics. So you have to increase the public awareness to train primary and secondary health centers. The challenges, you could see the patients waiting, the graph is rising. Other challenges are to increase the transplant centers, creating trained persons, manpower, infrastructure development. DGF is around 35%, and we have to develop an ideal protocol for the maintenance of the deceased donor. Acute rejection rate is 38. You have to give a good induction immunotherapy. And the infection rate is also high. It is due to the induction chemotherapy, immunotherapy, elsewhere dialysis, emergency surgery in emergency theater. To scrutinize and prepare the patients by ourselves and maintain dialysis will reduce the infection rate. This is the graph. You could see the urosepsis. The infection rate is very high. Consent from donor, you can have a presumed consent which is being followed in European countries. Streamlining the act, the Transplantation of the Human Organs Act, make it compulsory for doctors or hospital staffs to ask for organ donation, identify people who work as a transplant coordinators, in medical legal cases, perform organ retrieval and postmortem in the same sitting. Organ donation awareness program, driving license with donor card clause, social education of public, tax exemption, honoring the donor families. Organ shortage is crisis. However, the crisis has a cure. Set up a collaborative projects, use television media for promotion, get religious heads to participate regularly, have transparency in the program, set up regional transplant coordinated forums. It is a teamwork. It's a government, bureaucracy, transplant coordinators, support staff, urologists, nephrologists, and anesthetists. Journey of a lift operator who is working in our institution. This is a transplant for whom I did. He is a lift operator in our institution, the private institution where at present I am working. So, what is the global role of the kidney transplant? Universal access to renal transplantation, breaking the barriers, shortage of organs, trafficking of organs, exploitation of poverty and ignorance, less expensive generic immunosuppressives, training, technical workforce, doctors, nurses and technicians, public-private partnership. Here in India, August 13th is celebrated as Organ Donation Day. You could see it is in 2014 in New Delhi where we had a organ donation this thing, and it was honored by our famous cricketer and the Supreme Court judge. For that which is born, death is certain, and for the dead, birth is certain. Therefore, grieve not over that is inevitable. In my end is my beginning. Thank you.
Thank you, Dr. Mehta. I think now we have got the President of the Urology Association of Nepal, Dr. C.S. Agarwal. He is going to give the closing remarks. Thank you, Dr. Mehta.
Thank you. Thank you.
Good morning. Greetings from Nepal Association of Urological Surgeons. I am really honored to give closing remarks as President of NAUS. This is the second year of this session. In the first year, the presentation were from Nepal only. This time, you can imagine that the past president of USI, Dr. Maypan, has delivered his lecture in this session. So this is very prestigious sessions. We have lot of papers from Nepal, but were not included due to the shortage of time. Because of this, we were not able to talk what we are doing in developing urology in Nepal. We were not able to include papers on laparoscopic, female urology, andrology, and so many other disciplines. So, I would like to thank my preceders in Nepal and the past presidents of Urology Association of India and the President of Urological Association of India, and special thanks to Dr. Sabnis from our association for conceptualizing and making happen the joint session of USI and NAUS. So I hope this will be further increase in the time, and I hope the big success of this joint session. Finally, I would like to congratulate all the presenters from Nepal and India for making this session, and I also like to thank Professor Dogra and Professor Sabnis for chairing this session. Thank you very much.
Thank you, Dr. Agarwal. I think I, on behalf of me and my other co-chair persons, we thank all the speakers and the audience for this first session, really the first inaugural session of this conference. And I'm happy that we are rotating our dais 15 minutes before the allotted time. I think this is a good news and breaking news of today's session. So thank you everyone. Thank you very much.
Well, that indeed was